So hello everyone. In the last few sessions, we were discussing about types of keratoconus and different classification of keratoconus. So we had discussed about Rabinowitz criteria and different other criterias for about keratoconus. So today we'll be continuing with ASOCT. So the minimum median cutoff value is 62.6 microns. If there is an elevation or if there is a cutoff value of 62.6 microns, then the patient is suspected to be keratoconus. The inferior superior, the average thickness of the inferior and octant minus that of the superior octant cutoff value will be about 31.3 microns. The inferior temporal and superior nasal, the average thickness of the inferior temporal octant minus that of the superior nasal octant cutoff value is about 48.2 microns. The minimum cutoff value is 491.6 microns for keratoconus. If it is more than 491.6 microns, then the patient is normal, and if it is less than 491.6 microns, then the patient can be categorized under keratoconus. Vertical location of the minus location superior to the corneal vertex had positive values, and locations inferior to the vertex had negative values, and the cutoff value is about 716 microns if we are considering about the periphery. The advanced signs of keratoconus will be folds in Descemet's and Bowman's membrane, advanced cone formation seen in profile, scarring in corneal epithelium or subepithelium. Opacity at the apex can be observed. Focal rupture and fleck-like scar in Bowman's layer. അതായത് ഇൻ കേസ് ഓഫ് അഡ്വാൻസ് കെരട്ടോകോണസിൽ നമുക്ക് കോമൺലി കാണാൻ പറ്റുന്ന സൈൻസ് എന്തൊക്കെയാണെന്ന് വെച്ച് കഴിഞ്ഞാൽ ഡെസിമെൻസ് മെമ്പറൈൻ ബോമൻസ് മെമ്പറൈൻ ഫോൾസ് കാണാം. അഡ്വാൻസ്ഡ് കോൺഫോർമേഷൻ നമ്മുടെ ഓവറോൾ പ്രൊഫൈൽ നോക്കിക്കഴിഞ്ഞാൽ the corneal shape will change from an aspheric to a conical one. Scarring in corneal epithelium or subepithelium can be observed. Then opacity at the apex can be observed. Focal rupture, fleck-like scar in Bowman's layer can also be observed while performing ASOCT. Then the next one will be Rizzuti sign. Conical reflection of the nasal cornea when pen light is shown from the temporal side. So consider if the patient does got a if the patient's cornea is normal. So we got a normal cornea. If we'll project light from one end, it will form a point focus because the whole cornea will act as a lens, and the light reflector, if we project a light source from the temporal side, from the nasal side or from the temporal side, we'll be able to see a reflex. But in case of keratoconus, the reflex what we observe in normal patients, the reflex what we observe will be somewhat diffused. But in case of keratoconus, what happens will be the reflex what we see will be specifically it will be a focused value. The next sign what we can observe is Rizzuti sign. Sorry, not Rizzuti. Munson sign. Protrusion of lower lid upon down gaze. So if we'll tell the patient to look down, we'll be able to observe the lower lid margin appears as a conical shape. Then Flesher's ring, iron deposits within the epithelium around the base of the cone, which is observed in brown color, best seen with broad oblique beam with cobalt blue filter. So over here in the white light too, we will be able to see a ringish segment. That the whole ringish segment is it's basically the um, margin of iris. Other than that, we'll be able to see a shadow which will be typically iron deposits on the base of the cone. And over here too, in the cobalt blue illumination, it is much more prominently seen. Then Vogue striae, Vogue line or striae, commonly we call it as Vogue striae, fine reluctant, roughly parallel striations or stress line of posterior stroma can be observed. Over here we can see there are rough striations which are vertical in shape due to disruption of the stromal lamellae that occurs as a result of corneal ectasia. So much prominently we can see the striae over here. Then while performing topography, determine location, curvature and size of the cone and corneal eccentricity value. SIMK is taken. Detection of subclinical keratoconus is important as it contraindication. It's a contraindication for refractive surgery. So while performing topography for any other procedure too, we need to screen the patient for keratoconus because subclinical keratoconus won't show much of a sign, but those patients are strictly contraindicated for refractive surgery. Conan astigmatic pattern. Over here in the right eye, we can see the central area is much protruded as compared to the other. So we can assume that the we can say that the cone of this particular patient is somewhat at the center and the size is very small. So we can say that the size, the type of cone over here is actually a nipple cone. In Placido-based topography, inferior steepening in power map can be observed while performing a topography. The same thing in the right eye, the inferior steepening can be observed, and over on the left one too. Sorry, on the other picture too, it's actually two different topographies. On the other picture too, you will be able to see the inferior drooping of cone. Then the next one will be keratoconus detection indexes. SIMK diopter power of the flattest and the steepest meridian from 3 to 9 rings of topographic image. If the patient is normal, then the value will ranges from 43.53 plus or minus 1.02 diopter, and suspected keratoconus SIMK will be more than 45.57 diopter. Surface symmetry index, average difference between corresponding points 180 degree apart on 128 sequentially spaced meridians. The spherical surface asymmetry index is 0. If it is higher surface asymmetry index, high asymmetry can be observed. Corneal irregular measurements, degree of irregularity, standard deviation between cornea being measured and toric reference surfaces. So if it is normal, then it is around 0.03 to 0.68 micrometer. Suspected, it will be 0.69 to 1 micrometer, and diseased cornea 1.10 to 5 micrometer difference can be observed. Surface regularity index, regularity of the cornea in central 4.5 millimeter diameter. It measures the difference in power grading between successive ring pairs in 256 equally spaced meridians. Perfectly regular corneas will have a surface regularity index of 0.5. Normal cornea, which will be less than 0.56. So if it is more than 0.5, then that can be a suspect of keratoconus. Inferior superior asymmetry, power difference between 5 points on inferior hemisphere and 5 points on the superior hemisphere located 3 millimeter from apex, spaced at 30 degree intervals are being measured. So the normal values will be less than 1.4 diopter. Suspected keratoconic values will be 1.4 to 1.8 diopter. If it is uh, more than 1.8, then we can say that the patient is having keratoconus. Then KISA percentage indexes should be evaluated. If it is more than 100%, then that's basically a typical sign of keratoconus. Then keratoconus prediction index. So keratoconus prediction index will also give an idea. So if the keratoconic prediction index is more than 0.38 is pathological. The next one will be keratoconus classification index or Kleismeda method designed for TMS 1 topography. Export system that combine KPI with binary decision tree for calculation. KPI is combined with DSI, OSI, CSI, SIMK2 in reaching the decision. Expressed in 1% higher, more chances for keratoconus is there. Keratoconus severity index or cases small neural network developed for TMS1 topography detect presence and absence as well as grading of keratoconus. If it is normal, if it will be less than 15%, suspected 15 to 30, and more than 30 will be mentioned as keratoconus. Distant direct ophthalmoscopy will give a oil droplet reflex because of the increased power of cornea. Will be able to see a shadow or the focal point of the rays which are being focused on the vitreous, so which will be observed as an oil droplet reflex. Spontaneous perforation is rare. Tear in Descemet's membrane or sudden development of corneal edema or acute hydrops is can be observed. Acute hydrops is basically the Descemet's membrane rupture. Then corneal edema with stromal scarring can also be observed. Break in posterior corneal heals in 6 to 12 weeks. Corneal edema then disappears, but stromal scarring may be left. Some may regain vision after a resolution of hydrops depending on the extent and location of the scar. So hydrops specifically നമ്മൾ പറയുമ്പോൾ hydrops എന്ന് പറഞ്ഞാൽ എന്താ ഉദ്ദേശിക്കുന്നത് the Descemet's membrane rupture ഉണ്ടാവും Descemet's membrane rupture ഉണ്ടായി കഴിയുമ്പോൾ the aqueous humor will rush into the corneal stroma which will end up in corneal edema. So the total edema plus scarring അല്ലെങ്കിൽ ആ റപ്ചർ ഉണ്ടായതുകൊണ്ടുണ്ടായ സ്കാറിങ് കാര്യങ്ങളെല്ലാം വെച്ചിട്ടാണ് നമ്മൾ ഹൈഡ്രോപ്സ് എന്ന് പറയുന്നത്. So basically localized edema can be observed. Severe diffused edema can also be observed. രണ്ടും രണ്ട് പാറ്റേൺ ഓഫ് എന്താ പറയുക സൈൻസ് ആയിട്ടായിരിക്കും നമുക്ക് കാണാനായിട്ട് പറ്റുക. Then once the whole thing is been healed, then we might be able to see a latent scarring too. So scarring can be observed over here. Other characteristics of keratoconic eyes will be reduced corneal sensitivity, reduced tear breakup time, sodium fluorescence staining. We will be able to see more stained spots because of the irregularity of the cornea. Rose Bengal staining will show more staining on the corneal area because of the reduced TBUT plus the necrosis of the tissue. Reduced goblet cell sensitivity can be observed. Conjunctival squamous metaplasia can be observed. Disordered tear quality can also be observed. Then differential diagnosis will be Terence marginal degeneration. Corneal ectasia is limited to the peripheral cornea, affect both the inferior and superior cornea. Area of thinning is vascularized, has associated lipid deposits on that thin area can be observed. Then pellucid marginal degeneration. Corneal thinning is located in the periphery of the inferior cornea with a narrow band approximately 2 millimeter wide of unaffected cornea adjacent to the limbus. Usually bilateral, may be asymmetric, cause large amount of against the rule astigmatism. Difficult to fit successfully with a contact lens because of the peripheral corneal thinning, not good candidates for penetrating keratoplasty. So we can see in case of pellucid marginal degeneration, the thinning as well as the protrusion of cornea, which will be near to the limbal region. So because of that, that same, we won't be able to fit the contact lens perfectly because the edges won't fit properly in that same scenario. So in normal RGP as well as soft lenses, it will be very difficult to fit. So if the patient is having any pellucid marginal degeneration, then the preferred option is like to go with a large diameter lens. Then the management will be, we need to tell if the patient is having some sort of eye rubbing. We need to tell the patient not to rub their eyes. In case of mild mild keratoconus, we can correct the same with spectacle. If contact lens RGP, especially in case of without central scarring, we can prescribe an RGP. Central subepithelial scarring removed by nodulectomy and after fit with a contact lens. If there is a scar, then we can remove the scar surgically, and then after that we will be able to fit a contact lens in a much better manner. So if the patient is having some sort of pain, then a cycloplegic agent can also be prescribed to reduce the ciliary pain. Treatment for acute hydrops to reduce the pain, again cycloplegia. Hypertonic 5% saline ointment and patching can be done to draw some water from the cornea. Soft bandage contact lenses with a with a hypertonic solution, which is dipped in a hypertonic solution, also can be applied on top of the cornea. Then to reduce the discomfort and all, we can fit a bandage contact lens. Accelerated resolution intracameral gas injection can also be done to promote the healing. So simple classification, disease severity, early, if it is early, non-surgical spectacle torics of contact lenses can also be dispensed. In surgery, which will be riboflavin, UVA therapy, which will be C3R. Moderate, if it is moderate, then we can prescribe with RGP, hybrid lenses, piggyback lenses, and surgical optical correction will be intact, which will make the cornea a bit more regular and the patient will be able to see clearly. Advanced semi-scleral or scleral lenses, lamellar keratoplasty or penetrating keratoplasty can be done in surgery. Surgery indicated RGP lens intolerance, development of stromal opacities, corneal hydrops, significant lens decentration or any inability to retain lenses on the eye, increased astigmatism or irregular astigmatism are the indications for surgery. Index, intracorneal ring segments, corneal collagen cross-linking with riboflavin can also be performed to stop the progression or to delay the progression. Penetrating keratoplasty can be done. Deep anterior lamellar keratoplasty can also be performed. So intracorneal ring segments are basically PMMA or a rigid material ring which can be inserted into the stroma, which will stretch the cornea on opposite sides. While inserting the rings, the elevated cone will get stretched to both the sides, so we'll be getting a flatter central area, hence the vision will be improvised. Initially designed for refractive corrections, now primarily used to remodel corneal shape in eyes with corneal ectasia. Helps directly in improving visual acuity or indirect improvement by contact lens fitting. So once we achieve a somewhat flatter cornea, we'll be able to fit the same patient with contact lenses. Contact lens ineffective in advanced keratoconus where cone become pronounced. So types will be Ferrari ring, intacs, Ferrara rings and Mayo rings. Implanted by creating a tunnel in the corneal stroma manually or using femtosecond laser manually. Geometric center of the cornea or pupil is marked. Incisions are made 70 to 80% of the corneal thickness. Suction ring is placed on limbus to ensure fixation. Tunnel is created in stroma on each side of the incision using semicircular dissectors that dissects in clockwise and anti-clockwise direction. Segments are inserted in the stroma. Sitting can be opted if there is no risk of complication. use of femtosecond second laser. Instead of using a dissector, what we do is we'll be using a femtosecond laser to create the same incision. Then once the incision is made at a thickness at a depth of 70 to 80% of the total cornea, we'll be inserting the rings into that same area. Then C3R will be a procedure to make the collagen fibers a bit more stronger. So the name itself, it says states corneal collagen cross-linking with riboflavin. Use of combination of photosensitive substances like 1% riboflavin with or without 20% dextran is used, and it's stimulated by UVA. Riboflavin forms reactive oxygen species. Um, so dextran, osmolar stabilization, and maintenance of corneal thickness during the procedure. If the thickness is quite low, then we can make the cornea edematous and maintain the thickness so that the UVA rays won't reach up to the endothelium and it won't damage the whole endothelium. So UV photopolymerization is being done, which will make the riboflavin joined with the collagen fibers which are there. Hence, we'll get a rigider collagen, and the keratoconus progression can be stopped. So cross-linking, increased stiffness, change in biochemical and bioelastic behavior of the tissue, different visual, refractive, topographic, and aberrometric changes can be observed because of the strengthening of the cornea. Surgical technique, standard epithelium of protocol, topical anesthesia is being instilled, corneal epithelium 8 to 9 millimeter is basically being removed, corneal stroma saturated with isotonic 1% riboflavin and 20% dextran solution, instilling 1 drop every 2 minutes for 30 minutes. Complete stromal saturation. Once we achieve complete stromal saturation, which is been checked with slit lamp, then UV radiation at 5.4 joules per centimeter square or 3 microwatt per centimeter square for 30 minutes is being applied. Therapeutic contact lenses with topical corticosteroids, antibiotics, and non-steroidal anti-inflammatory agents is fitted until regeneration of the epithelium happens. So, reducing the postoperative complications, transepithelial on protocol can be performed. So, altering epithelial permeability with benzalkonium chloride is done. So, if we'll instill benzalkonium chloride, the tight junctions of the epithelium will be loosened up, and through that the riboflavin can be penetrated into the corneal stroma. So, mechanical modification is done, direct application. Then introphoresis, reducing treatment time. Then the next one will be refractive surgery, penetrating keratoplasty. Indication, contact lens intolerance with good vision, poor vision with even with a comfortable contact lens may due to scarring, unstable contact lens fit even with a good vision and tolerance, progressive thinning to periphery, approaching limbus requiring very large graft. Excellent prognosis can be achieved. Then DALC leaves host endothelium untouched, thereby potentially decreasing rejection episodes. Refractive procedures include LASIK, and LASIK is contraindicated. Then keratoglobus, thinning and hemispherical protrusion of the entire cornea, which develops globular generalized thinning, and which is very rare as compared to keratoconus. No, it's a non-progressive disorder. So bilaterally we will be able to see a keratoglobus. Congenital autoimmune response. Because of autoimmune response, we will be able to see congenital keratoglobus. Familial and hereditary history will be there. Ophthalmos and megalocornea can also be observed. So if we'll compare keratoconus and keratoglobus, the whole cornea will be protruded out, and the whole cornea we'll be able to see thinning at the whole corneal level. Acute hydrops is rare, more prone to rupture on mild trauma, and we need to protect that same. Surgical difficulties will be there. Contact lens will give unsatisfactory fit as well as vision. Intrastromal ring segments and cross-linking can be uh, performed, but it won't work that much. Then posterior keratoconus, which is a very rare condition, sporadic in nature. Slight cone-like bulging in the posterior surface of the cornea can be observed. Unilateral, non-progressive increase in curvature of the posterior corneal surface can also be observed. Then in the anterior surface, we won't be able to see any such changes. Visual acuity relatively unimpaired because of the similar refractive indexes of the cornea and the aqueous humor. Type will be generalized. Involvement of the entire posterior corneal surface, localized, paracentral or central posterior indentation can be observed. So here in the optic section, we can see a small conic depression at the posterior most portion, which is basically being termed as posterior keratoconus. Then the next one will be keratectasia, very rare, usually unilateral, uh, condition through condition thought to be the result of intrauterine keratitis and perforation. It is characterized by turbulence between the eyelid of a severely opacified and sometimes vascularized cornea, often associated with raised intraocular pressure. Then pellucid marginal degeneration. So the definition will be rare painless progression, bilateral peripheral corneal thinning, typically affects the inferior cornea. So in the picture we will be able to see, we will be able to, the central cornea will appear comparatively normal, which will be able to see the thinning, which is approximately 2 millimeter from the limbus inward. Uncommon, non-hereditary, bilateral, pellucid, which means transparent. Inferior peripheral corneal thinning is in absence of inflammation, and etiology is basically unknown. Presentation is usually in adulthood, may occasionally occur in conjunction with keratoconus, no conjunctival injection. Then a lipid deposition or corneal neovascularization won't be there. Protrusion of the cornea above the band of thinning, sometimes a clear uh, distinction between pellucid marginal degeneration and keratoconus is not possible. If the cone, in case of keratoconus, if the cone is oval and it is drooped to the inferior quadrant, then it will be a bit difficult to mention what type of keratoconus does the what exactly is going on over there, like whether it is PMD or keratoconus. Then differential diagnosis, keratoconus. If it is keratoconus, then the protrusion of point of maximum thinning can be observed. PMD, superficial or inferior, superior or inferior, and protrusion above area of maximum thinning can be observed. Neovascularization of lipid deposition can be seen in case of PMD. Then posterior stromal scarring within thinned area can be observed. Then diagnosed at an age between 20 to 40 years, men and women affected equally. Decreased vision, rather high astigmatism can be observed. Acute hydrops and raised spontaneous corneal perforation can be observed because of the thinning. So over here, the main difference is like the inferior most portion, which is somewhat near to the limbus, is basically being um, which is basically being protruded out, and the central or the superiormost portion of the cornea looks normal while observing in slit lamp, and especially while doing a topography, we'll be able to see a lobster claw appearance. So we will be able to see like a claw of a lobster or a crab, which indicates pellucid marginal degeneration. Symptoms will be slowly progressive blurring due to astigmatism. Signs bilateral, slowly progressive crescentic 1 to 2 millimeter band of inferior corneal thinning extending from 4 o'clock to 8 o'clock, 1 millimeter from the limbus. Uh, 1 millimeter inward to the limbus, if we'll say, to the center of the cornea, what we if we'll say. So epithelium is intact and the cornea above the thinned area is ectatic and flattened. Myopic against the rule of astigmatism can be observed in the scenario. No anterior chamber reaction can be observed. So diffuse astigmatism over here too will be able to see the lobster claw pattern, which indicates PMD. May occur in conjunction with keratoconus. Flesher's ring and Vaux striae do not occur. Rarely, acute hydrops can be seen. And the management will be early suspects and contact lens. Early spectacles and contact lenses can be prescribed if the astigmatism is low. Surgery, large eccentric penetrating keratoplasty, thermocauterization to increase the rigidity of the cell so that there won't be any rupture. Crescentic lamellar keratoplasty can also be done. Wedge resection of the diseased tissue, and then epikeratoplasty, then intracorneal ring segment implantation, which is very difficult to do in case of PMD because the protrusion as well as the thinning will be extremely to the inferior quadrant. Then C3R can also be performed. So that's all about keratoconus. So kindly go through the presentation and please do let me know if there is any doubts. So the last few slides were we discussed it in a hurry manner, so because of the time and all. So just go through the presentation and please do let me know. Thank you all.